My clock shows 12 noon. If you guys would like to, I can go ahead and get us started. But welcome to everyone who's on the call and who are joining us now. This is the CMDA monthly meeting on Tuesday, June 3rd. I'm Sing Pallet, the president of CMDA, and I'm joined by co-hosts today, Doctors Chris Horton and Leslie Eber. Thank you all for being here. So we thought we would start with some updates today, but we want to make sure that the people giving updates are on the call. And if they're not, maybe we can just come back to them later. And our clinical presentation today will be on wound care, specifically on the skin substitutes and things that we ought to know about them. Chris, would you like to introduce our speakers? Because I don't see Jenny or Chris on yet. So
Yeah,
maybe just
absolutely. I don't know, maybe they're at a big meeting or something, but yeah, I think we have two amazing speakers today, Dr. Raj Rai, Dr. Danielle Whitacre, and I think we were going to start with you, Dr. Rai, since you're going to give us a little more overview, and then I believe Dr. Whitacre is going to give some real life practice experience, and feedback and vital information for us all to consider moving forward. So if you're ready, Dr. Rai, do you want to pull up your slides and run them from your computer, or we can do that?
Thanks, Chris. Yeah, if you don't mind running it from yours, that would be great if it's not too much trouble.
Yeah, let me, there we go. Sing or someone has them.
yeah, I can share it.
Oh, can you, yeah, slideshow.
I will do that.
Yeah, do you, trying to get them pulled up.
Just pulling them up now, I think.
Yeah.
Chris, thanks for the kind introduction. While you're pulling that up, I'll just kind of give an overview of what we'll be talking about today. So we have, as Chris mentioned, myself, followed by Danielle Whitacre from Bloom, who we both got some unique perspectives for skin substitutes and what we see. And so what I'm going to do, next slide, please, is kind of give an overview of just wound healing in general. Some of this is probably taking you back to school, and we'll probably give you some PTSD. It's stuff that I thought I'd never have to look again, but here I am doing wound care, and it's very important. We'll talk about some of the wound healing phases, and then mention a little bit about the placenta. There are a lot of skin substitutes out there. They've been around for many, many years, and what we're going to focus on today are the use of placental products, and mechanism of action in wound care. And then I'll kind of tap out, talking about a little bit of the economic implications. And then, as Chris mentioned, Danielle is going to jump in with some of her sort of real world experiences and what she sees on her end. So really, hopefully, a fascinating overview about skin substitutes, and I hope we hope you learn a lot from it. So appreciate the board giving me an opportunity to present. Next slide, please. So here's the initial slide that, like I mentioned, will probably give you some PTSD. So we'll talk first about the phases of wound healing. I think this is relevant just because we see so many wounds, and we wonder why they're not healing. And just to give you an overview, very, very high level. I promise I won't go too much into detail, but we'll give you an overview of those three phases. So first phase is the inflammatory phase. This is immediately following injury to the skin. Wound formation activates a clotting cascade, and involves a temporary release of vasoconstrictors to reduce bleeding, and then you get a fibrin clot that's formed. So that clot is formed of collagen, platelets, thrombin, fibronectin, and all these basically stimulate the release of cytokines and growth factors. And so from a time standpoint, you can see there on the slide, there's a temporal movement through these three phases. And so once you get out of the inflammatory phase, you move over to the proliferative phase, and there's a variability there between the, of course, the type of injury. Are there any other circumstances surrounding the injury? Are there any infections? Things like that just kind of can dictate how quickly it moves from inflammatory to proliferative. So the proliferative phase is really known as kind of like the building phase. It's characterized by epithelialization, angiogenesis, granulation tissue formation. And the cells that are really involved in those things are the fibroblasts and the endothelial cells. They're really the primary cells that are involved during this phase. And then epithelialization, begins as soon as the wound occurs and is stimulated by the inflammatory cytokines and the growth factors I mentioned from the inflammatory phase. Keratinocytes then are stimulated to migrate into the wound area, and they proliferate, they differentiate into the epidermis, and then angiogenesis occurs simultaneously, stimulated by local hypoxia, and then growth factors like VEGF and PDGF, vascular endothelial growth factor, and platelet-derived growth factor. So once you get through those first two phases, then you're going into kind of the final phase before the wound is actually healed. So you go to the remodeling phase, where granulation tissue formation ends and the wound maturation actually begins. So this phase, if you can go to there, Chris, you can go to the next slide. This phase is characterized by reorganization of collagen fibers. You get contraction of the wound edges. And then the tissue is then remodeled and organized in an orderly manner to strengthen that repair. So type 3 collagen during this phase is then replaced by type 1 collagen. And this increases the overall tensile strength of the wound. Next slide, please. This is, to me, probably the most important slide out of the entire deck. And I'm going to come back to it again in a few minutes, but I really bring it up just because, no matter which products you use, whether it's a gel or an alginate or a wound vac, the factors that impede wound healing are always the same. Doesn't matter if you use an allograft, a skin graft, surgery, whatever you're doing to try to heal your wound. If you don't control these factors, so if you don't control infection, venous insufficiency, these are local factors, oxygenation. So you think about diabetics, you think about smokers, and then systemic factors, of course, as well. Same thing, diabetics, obesity, compliance, whether they've been on medications like steroids, and obviously things like radiation and chemotherapy can also affect the healing of the wound. So if you're not controlling these things, it doesn't matter which product you use, your wound's not going to heal, right? So lifestyle, of course, makes a big difference as well. So I'll come back to this slide in a few minutes, but we can go ahead to the next slide. So what is a wound? And I mean that kind of more tongue-in-cheek, so to speak. So the wound, if you go back to that the first animation that I had at the top, is when, and becomes chronic, I should say, when they fail to progress through those phases. And typically what happens, especially with a chronic wound, is they get stuck in that inflammatory phase. And a chronic wound is basically one that fails to proceed through a normal and orderly process in a timely sequence of repair within an expected time frame, usually within about 3 months. If the wound is not healed, it then becomes chronic. So often these wounds remain in a prolonged state of persistent inflammation. So basically sticking in that first phase, and then they become unable to progress to the next phase of wound healing. And that's where you get a chronic wound. Chronic inflammation plays a crucial role in the activation of fibrosis. You get a lot of scarring. And when the wound healing becomes very dysregulated, collagen deposition becomes also very dysregulated. And then you get this irreversible accumulation of fibrotic connective tissue by the myofibroblasts. And so the most common types of chronic wounds are the arterial ulcers, the diabetic ulcers, pressure ulcers, venous ulcers, all the stuff that we see in our patient population. Next slide, please. So, excuse me, I mentioned in the earlier slide, the local and the systemic factors. So if you think about it from a very simplistic standpoint, arterial ulcer, if you have an arterial ulcer, what are you going to do? If you want to heal it, you can put all of the hydrogel and the silver gel and those things on it. But if you don't control the fact that the blood flow isn't good, you're never going to heal that wound, right? You'll probably have to send them out to a vascular surgeon or an interventional specialist to help and revascularize that area. And then if you look at the other side, you look at the venous stasis wounds, you need compression, you need elevation, and if they're able to, you need some exercise. Diabetics, you want to control their blood sugar and any peripheral arterial disease. And then with pressure injuries, you've got an issue that occurred because offloading didn't happen or repositioning didn't happen. So those are really the basic tenets of wound care, very similar to the earlier slide where we talked about the local and the systemic factors. So if you're not doing these things, once again, your wounds are not going to heal. Next slide, please. So we'll jump forward to what the main topic is today. And so I just want to give you a big overview of wound care and then jump into the skin substitutes, the placental products. And we all know what the placenta is. It is a temporary vital organ. It's usually discarded as medical waste. This makes it, in the crudest sense, very easily accessible. It's cost effective, and it's also technically an ethical source of raw material. In addition to its availability, though, the placenta possesses several desirable biological properties that are innate to healing. So it's angiogenic, it's anti-inflammatory, antimicrobial, antifibrotic, immunomodulatory, and also has low immunogenicity. Next slide. So placental tissue has unique extracellular matrices, notable structure and mechanical properties, including elasticity, stiffness, and tensile strength. So kind of going back a little bit again to biology, the amniotic sac is a very thin, semi-transparent membrane, holds the amniotic fluid for the developing fetus. It's composed of two main layers, two general layers, the amnion and the chorion, the amnion being avascular, and the chorion being the highly vascularized layer. And then in between the two is sort of an intermediate spongy layer that's composed mostly of type 3 collagen, also has a very high abundance of proteoglycans and glycoprotein. And it loosely connects those two layers, the amnion and the chorion, which allows the two membranes to be separated very easily by blood dissection. Next slide. So before we get a little bit further into it, just kind of how do you go from the placenta to a skin substitute or into an allograft, right? So essentially when you're doing your screening and your testing, excuse me, when you're screening and testing, you're of course going to get a medical and social history of the donor. You'll then also do serological testing for any communicable diseases. And then essentially you move on to the processing phase, the real processing phase, where you have decellularization and cleansing of the layers. And so you can do that in a variety of different ways, enzymatically, using proteases or nucleases. Chemicals can also be used, such as detergents or acids, and then different tonicities of fluids like hypotonic and hypertonic solutions. And then physically, it can also be separated. The layers can be separated by pressure, hydrostatic pressure, and even temperature changes as well. So a lot goes into the processing of these tissues. And then, of course, the preservation. If you ever come across a skin substitute, you're probably going to want to know a couple of things. One, you're going to want to know how it was preserved. Was it cryopreserved, meaning was it frozen, or was it dehydrated? Now, the dehydrated form is going to be more stable. They basically taken out all the, just like the name says, obviously, it's dried, it's available for storage for a long period of time and much more easily transported. If it's done by cryo, then this obviously requires, temperature control, temperature regulation. And in that state, it has to be kept in that state prior to use of that product. So, and then the other aspect is it an amniotic layer, a single layer, or is it a double layer? And then of course the product itself is sterilized. So next slide, please. So single layer amnion is very thin. It's ideal for superficial wounds, rich in growth factors, anti-inflammatory proteins, and extracellular matrix components. Because it's so thin and almost transparent, you can basically see through the product and just see your wound just right through it. However, it does have lower mechanical strength. So there are some drawbacks to it, but it's really more just for superficial wounds. Next slide. The second type is the double layer. So this is the amnion and the chorion. We talked about the intermediary layer. And the chorion, when you combine with the amnion, it's obviously going to be a little less transparent. When you have the double layer, it's going to have greater mechanical strength. It's thicker, more robust, and provides additional architectural support. And really can be used for deeper wounds, wounds with undermining, wounds with tunneling. Next slide. Now you'll probably ask, like, why is there a chorion layer only? And you can technically separate out the chorion from the amnion and then try to use the chorion, but it has far fewer growth factors, and there's very limited clinical evidence for use of chorion only allografts. It is thicker, it's stronger, but without the growth factors, it doesn't really provide a lot of utilization. So just kind of wanted to mention that, since I'm sure somebody's probably wondering. Next slide. So I come back to this slide. I mentioned that I would come back to it. And the reason I'm coming back to it once again is that I mentioned earlier that if you're not controlling for these factors, it does not matter which product you use. It doesn't matter if you use an allograft. It doesn't matter if you use, like I said, hydrogel, honey, silver, alginate. It doesn't matter. If you're not controlling these things, the wounds just are not going to heal, right? So basic tenets of care, you're going to have to control the factors that actually led to the development of that wound. Otherwise, you're just going to sit in that cycle forever and ever. So I just wanted to come back to that. I know Danielle is going to talk a little bit about this and some of the stuff that she sees. From there, I just wanted to mention that one more time. So next slide, please. So the economic impact of chronic wounds. I'm going to just touch on this just for a minute and give you just a really fine look at what the economic impact of an actual chronic wound is. So from studies, 1 to 2% of the population will develop a chronic wound, and that's a huge number. And of 8.2 million Medicare beneficiaries annually, right? So an estimate of between $28.1 billion to $97 billion is the economic impact of these chronic wounds, and it's an alarming number of patients. It's supposed to rise given the combined effects of aging and the rising rates of diabetes and obesity. They represent certainly a significant economic burden to the healthcare system. Next slide, please. So moving further, and Dr. Whitacre was actually referenced in this one of these New York Times articles. So 2024, $10 billion was spent on skin substitutes, on allografts in particular that came from placental products. That is a 2x rise from the 2023 number. That is, if you think about it, and the New York Times actually quantified it and said, this is actually more than ambulance rides, CT scans, and anesthesia. So that's a pretty significant number and a big jump from 23 to 24. Next slide, please. So interestingly, the article talks about reimbursement, and this is where I'll sort of turn it over to Danielle in just a second. From what CMS will reimburse, and it's a very interesting algorithm that I know that's probably been in the news a little bit the last few months, actually since January, and then again in February and April, and trying to reassess how these reimbursements work, because it is, as providers, we have a responsibility, in my opinion, to choose products that work, to choose products that are efficacious, but also that meet the standards for care, but at the same time also being conscious of price, right? So what's interesting about the way that these allografts have kind of permeated the market is that there's a lot of incentives there that are kind of questionable, and I'll kind of elaborate a little bit on that before I turn it over to Danielle. So right now, CMS basically reimburses from a product that's developed, the allograft, whether it's an amnion or chorion, it basically reimburses at any price that is set, even if it is above the average for that particular product. This then continues on for about 6 months, and then after that 6 months, a repricing will occur, and that's done by CMS. And then guess what? The company that actually manufactures those products then come out with a quote unquote new product, and then they can reset the price for another 6 months. And so you can see from thinking about that, what actually happens is, and I'm not saying all the companies are like this or anything like that. I just think that there's some questionable tactics, perhaps is the right word, from a pricing standpoint, that that can have an impact on how the reimbursements are actually met, I guess is the right word for it. So in order to, in some ways, I guess, incentivize practices to use their products, because there are hundreds of them out there now. Back in, I think, 2022, 2021, there were maybe 100, 115 products. Now there are probably 4 times that many out on the market. And so what because it's so competitive and because there's a lot of money involved, the manufacturers will then offer practices, when they buy in bulk of 2 or more, they'll actually offer them a discount. So if anywhere from 25 to 40 to 50%, which then the practice can keep. So, okay, that's, buy and bill. Some of us are familiar with those practices. Say what you will about them, but let's kind of dig into those numbers just a little bit more before I turn it over. Next slide, please. So, sorry. Yep, that one. So this is, I probably get a call from a skin sub manufacturer probably once a week right now, maybe even more than that at times. And this was, there's no name on here or anything like that, no identifying it, but any identifying information. So this was a pricing sheet that was sent to me, or left at my office. And you can see from this product, and this is not a low end product. Obviously, this is not even actually the highest end product, but this was a ordering sheet for 4 products that this company manufactured. 2 by 2 centimeters, that's 4 square centimeters. That is a fairly small size one. That's $8,000. If you go up to the next bigger size, 2 by 4, double the cost. If you go to 4 by 4, and obviously you're going from 4 centimeters to 8 square centimeters to 16, on and on, 28 square centimeters, right? So if you're offering the practice an incentive, if you will, or a discount, if you will, of anywhere from 25 to 40%, you can do the math on it. Let's say on the low end, for the lowest cost product, the $8,000 product, that's a $2,000 sort of discount, if you will, that the practice then keeps. And so if you use those products, and they can be used for anywhere from 8 to 12 weeks, you can do the math on that. 2,000 times 8, $16,000 just for one 2 by 2 wound. You go up to the higher price product, and this is once again on the lower end, the $55,000 product. 25% of that is a significant number. We're approaching almost $15,000 that the practice can actually keep. You do that over the course of 8 to 12 weeks, that's 15 times 10. On average, it's $150,000 just that your practice can keep. I'm not trying to endorse people to do this, obviously, but I'm just trying to highlight the impact, because a lot of people that are using these products are promoting them as, without taking into account, if you go back to my earlier slide on controlling factors for wound healing, they don't look at compliance. They don't look at diabetes. They don't look at all of the other things that make the wounds heal. They just want to get this product on the patients. And so Dr. Pallett, actually, Singh, wrote a very nice article on collaboration of skincare product, or excuse me, skin products, skin substitutes, and wound care in general, with working with the primary care physician that's in your building. And so I think it's very important. It was a very pertinent article to highlight why it's important to make sure that if you have a skin sub company, once again, not saying they're all bad, these are effective products when used appropriately, and when they're used in concert with controlling the local and systemic factors of those patients. And so I'll stress that, a lot of the companies that come in, they'll throw a product on and they'll put a note on it that says do not touch for 1 week. They don't want that touched for a reason. And I'm not saying they're all like that, but there are a lot of nefarious characters that are out in the market right now that I just think it's important to highlight. That sometimes the incentives can be a little bit overwhelming, and can force people to use products when they're not necessary. So just be aware. I wanted to highlight that to you just before I turn it over to Danielle. And I know she doesn't need an introduction, but Dr. Whitacre, CMO for Bloom Healthcare, I'll turn it over to her and hopefully shared a little bit of information for all of you.
Yeah, thank you so much, Dr. Rai. I learned from your talk here, and I really appreciate the opportunity to speak about this topic to this group. And I'm going to try to share my screen. Let me see, sorry. Does not help that I have multiple screens open.
I had that issue too.
Yeah. Okay, share. It's probably showing my team now. Okay.
It's showing Zoom.
It's so, okay. Oh, goodness. That's the wrong screen. It's over here. Okay, I'm gonna get this. I'm gonna get it. Share. Screen 2. Okay. Can you see it?
Yep.
All right. Wonderful. So good. And hopefully I'll be able to. There we go. So yes, I'm a primary care physician. Full disclosure, I'm not a specialist in wound care. And I'm a part of a primary care practice that's home-based, and we're primarily caring for residents of congregate care settings, also private homes, but non-skilled environments. And we are serving patients as far north as Fort Collins, all the way down to Colorado Springs. So while I'm not a wound care specialist, we see a lot of chronic wounds in our patients, as all of you on this call are caring for a similar population, and we're all caring for chronic wounds. So Bloom is part of an accountable care organization. So a portion of our patients align with a high needs program, a high needs ACO REACH program. And in 2022, we for the first time had access to claims data on our patients, and we started to notice through the last quarter of 2022 a humongous spike in the use of skin substitutes. And anecdotally, we were also seeing a number of complications associated with the use of these products, and unfortunately, very few instances of wound healing. So it really got us to look at this issue. This is a graph that we shared with our Medicare administrative contractor to say, hey, something is unusual here, something is off. And we saw a huge spike, as I've mentioned, of expenditures related to the use of these products. And this is on a census of 750. So it was really alarming to us to see the increased use. And yeah, we reported this to our Medicare administrative contractor, appropriate authorities, and other ACOs have also done, have seen the same thing and have reported their concerns to our MACs. there have been some movement to try to change some of the regulations through the local coverage determination based on Bloom's and many other across the nation ACOs saying, hey, something's amiss here. And this is a graph that was in the New York Times. Dr. Rai had mentioned it. $10 billion was spent last year. This is similar to what, the graph here is similar to the exponential rise that ACOs across the nation are seeing as well, and have been sounding the alarm like, hey, let's look at this. So we raised that alarm. We've been to stakeholder meetings with our MAC and have expressed our concerns related to what we've been seeing with our populations and with some of these associations with increased complications. The Medicare Administrative Contractor Board has, asked to see some data on this to help with some of the decision making around how the use of these treatments are regulated. So Bloom took a look at our claims. So over a 3-year time span, where we had claims data available to us through our ACO REACH program. And with our census of over the years, 700 to, oh gosh, it's now we're 1,800 patients. We saw almost 270 skin substitute claims. So we looked at each one of those claims and went back to those cases. So we identified 27 patients where these treatments were used. And we looked at each individual case. We excluded 5 cases where skin substitutes were used for minor dermatologic procedures. And the rest of the patients cases that we took a look at, and population attributes you can see in the chart on the right hand side. So the population where we were able to look back at outcomes. The average age you can see there 69, median was 73. This is a little bit younger. It was skewed younger to our general population that we generally serve. It was also skewed male. So we saw that more males had these products utilized. And then the chronic disease burden you can see here, we looked at diabetes, peripheral vascular disease, dementia, and paralysis. The average CAT score was something else we looked at among these 20 patients. Recall CATS is a rating scale looking at activities of daily living. So the average with this population was 3.2. So that means 3.2 activities of daily living deficits of the 6 that CATS looks at. So a relatively chronically ill population with a chronic disease burden and debilitated.
Dr. Whitacre?
Yes.
I might have missed it, but how did you choose those 27 people to focus on out of all the 269 claims?
So those 269 claims were made on those 27 patients. And just to clarify, these skin substitutes are typically used on a weekly basis anywhere. And in our review, they were used in cases anywhere from 1 to 20 applications. So that's how you got 270 claims. They were individual treatments among those 27 patients. So excluding those 5 cases, we that had been used, the skin substitutes had been used for like a minor derm procedure. We looked at 25. We had access to the 25 events among 20 patients. And I'll point out a couple numbers here. So we looked just very simply at 4 weeks and 6 months. Were those wounds there, or had they resolved? So pretty simple. In only 2 of the 25 events where we saw resolution at both 4 weeks and 6 months. And I'll also point out that after 6 months, 5 of the patients had passed. Now, this was expected because of the population that we serve. They have limited life expectancy, so it's not unusual to have seen 5 of these events have at 6 months the patients had passed. And yeah, so it kind of highlights the fact that these treatments were being used in a population with limited life expectancy. So I mentioned that complications, anecdotally, we saw as being unusually high. And in this, of course, we don't have a comparison group. This is a very chronically ill population, frail. So it's really hard to say if the associated use of the skin substances were causative here, obviously. But I can say that to me, looking at 20 cases, to see 8 of those patients, of the 20 patients, experiencing 1 or more wound complications seems high. And to see 25% of the cases have complications severe enough to require hospitalizations it seems unusual. And I would say, yeah, I would say that when my patients are being treated with a comprehensive wound care strategy that's interdisciplinary, I don't tend to see numbers like this. Again, hard to say. If this would be if these same outcomes would have occurred had the skin substitutes not been involved. So a couple of things that I would say to the group that just based on our experience here and some of the concerning business practices that we see that raise some concern. I would say vet the entities you allow into your facilities. And when you have wound care providers involved in the care of residents, ensure that the primary care provider is aware of what's going on there. I can tell you that most of the cases in which our patients were treated with skin substitutes, most of the time we did not know about the skin substitute use until it was identified through claims. And additionally, sometimes when we requested records from the providers who were utilizing these treatments, it wasn't always transparent in the documentation. So it just raises concern that the lack of transparency there. And then I would also say be wary of those Part B entities. So entities charging Medicare for services, if they're offering free wound services to patients where there's no copay liability. And I'll point back to that graph that I was showing regarding our claims. The copay liabilities were thousands of dollars, yet we did not hear from our patients that they had any concerns about being charged for these services. I don't know about you, but when my patient receives a copay of $30 for a lab I ordered, sometimes I hear about it from a daughter or a concerned patient. So to see that through claims that our patients would be liable for thousands of dollars, just really makes me concerned that perhaps later, they might be getting a bill when Medicare sees that this is going on. So yeah, and then beyond that, looking at our our Medicare trust fund, and knowing that we as providers really have an obligation to be thoughtful about the cost of some of these treatments, especially if we're not really certain that we're seeing the benefits that are promised. So thank you so much for allowing me time to talk about Bloom's experience. I really appreciate the CMDA allowing this time to talk about this topic.
Thank you, Dr. Whitacre and Dr. Rai. Those were excellent presentations. I think something that we should all be aware of. Are there any questions after these two presentations?
I have a question. Dr. Whitaker, you're saying you should try to vet the entities coming into your communities. What kind of questions would you ask, or how would you go about vetting them? How could I tell the difference between a group that's doing the practice correctly versus a practice that's doing standard clinical medicine or following guidelines?
Right. Yeah, I think asking questions about the interventions that they're using, and I would not hesitate asking about skin substitute use and their practice behind that. I think it is difficult to assess. I think really making sure that they have a collaborative approach, I think, is probably another means to make sure they're really following a more interdisciplinary, comprehensive approach.
There is a question from Robert McCurry in the chat. Are you aware of the names of the entities that are not on the up and up with using the products?
I hesitate to name any names. Yeah, and I can say that even when I have learned of entities, a new one pops up. Like Dr. Rai has mentioned, Dr. Rai has been getting weekly requests from manufacturers, even primary care providers. Bloom Healthcare and other primary care providers have been approached about incorporating skin substitute treatments in our primary care practices. So in primary care providers out in the community are using this as well. This is not specific necessarily to wound care specialists.
There's another question in the chat from Dr. Shepard. Can you speak to the use of wound swab PCR versus wound culture prior to using these grafts? How does antibiotic stewardship fit in?
Yeah, that's a great question. I wonder, Dr. Rai, I know you've spoken with me about wound cultures and the use in wound care. I'll let you speak to that one if you wouldn't mind.
Thanks, Danielle. Good question, Dave. I think we may have talked about this subject before, a while back, regarding PCRs and obviously with antibiotic stewardship. PCRs give you, similar to urine PCRs, they give you a lot of information. And I think that's kind of the fascinating aspect of these PCR studies. whether it's urine PCR or a wound PCR, you're getting a ton of information there. And that can almost be overwhelming in the sense that you're like, wow, this is really cool. I get all this information about all the flora that may be present within the wound bed. But what that leads to typically is a significant amount of overprescribing. The gold standard for assessing bacterial, not just contamination, but actual infection within the wound is a wound culture, meaning you have to take a tissue culture, excuse me, and even with a wound swab, there that you have to reach that certain threshold of contamination within the wound bed itself before you can actually prescribe. And the PCRs don't tell you the actual bacterial load that's in the wound bed. So it's very important to distinguish, and I will even point out that there are many companies out there doing very similar things where they won't even tell you that they've actually drawn a wound PCR. It looks like a culture result printout, so you may not even realize that it's a PCR. So once again, very similar to what Danielle said, you've got to ask the question, what is this? And because it sometimes doesn't even mention it in the note, it doesn't even mention it on the results, that it's actually a PCR, or in a lot of cases that I've come across, you don't even see in the note from the wounds, the skin subs, that they actually apply to skin subs. So you may just get a note, dressing covered, leave in place, and then you don't see anything else. So it's very, when you talk about trying to ascertain the communication and to establish communication between these companies, if they're not being upfront about it, that's usually a bad sign. So yeah, just knowing the question to ask, as Danielle mentioned, is very important.
So
Can I follow that up with a question?
Oh, go ahead.
Sorry.
Yeah, so I have been told that it is standard practice to do a PCR wound culture on these before you ever apply them, and that regular wound culture is not the standard of care for doing this. Can you speak to that at all?
I'm happy to, Dave. That's not accurate. So what I've seen in my practice is what I've seen in the practice of others, I should say, we don't actually use the skin subs or the wound PCRs. But whenever a wound PCR is done, the cost, or excuse me, I should say the reimbursement for those wound PCRs can be upwards of $500 to $600 to the lab itself. You compare that to an actual tissue culture or a swab culture, not a swab PCR, which is $30, $40 maybe max, depending on the commercial insurance that's used. So there's, once again, there's a financial incentive there when those PCRs are utilized. Same thing that happens that we see with the urine PCRs when we're trying to assess urinary tract infections as well. You just get so much information, and because it's a PCR, it's reimbursed at a higher rate, but the amount of information that you get back for that is not necessarily something that you're supposed to act upon. As with a urine PCR, you're not going to, you see we see colonization all the time, but that does not mean that the wound is infected or the patient has a UTI.
Thank you. This has been a great discussion. There's a couple last minute comments in the comment section. If you guys have questions, if you want to stay on till the end, we're just trying to stay on track. And we definitely want to hear from Chad Fear if he's willing to give us an update from the health department. And so if you guys stay on and have questions at the end, feel free to do so. But if Chad would like to give updates, then we would love to hear from him.
All right, you bet. Yes, great presentation. What I wanted to bring to you today very quickly was some feedback, and it's a very short period of time. If you recall, there were changes to the state operations manual effective April 28th. So I've been kind of watching to see if there's any sort of noticeable change in citations, or results from the survey. And we've not seen anything in terms of the admission, transfer, discharge changes, changes with staffing, professional standards, quality assurance, really kind of etc. Except that we're seeing, I think, more citations around chemical restraints, and that has had to do with side effect monitoring or the existence of side effects. So needing to monitor the side effects of those medications or in the presence of those medications, looking at that as a potential or actual result of the medications use resulting in citation to deficient practice. The other thing that I would like to bring up is I think that we have perhaps to this point under-recognized issues with enhanced barrier precautions under F880 for infection prevention and control. And just real quick, this of course requires gown and glove use for high contact resident care activities when there's an infection or colonization with a CDC targeted MDRO, or there are wounds or medical devices, indwelling medical devices, if the resident is not known to be infected or colonized. And what we're finding is that that people are being identified as such, and we see the posting on doors that we would expect to see requiring the PPE use. But what we're finding is that there has been a varying degree of misunderstanding by staff as to what constitutes a high contact resident care activity. And in situations where this has been cited, there has they didn't see the activity as such. Things like dressing, bathing and showering, transferring, providing hygiene, changing linens, changing briefs or toileting assistance, device care, and wound care. So those are instances that we have seen that staff are maybe perhaps not recognizing as being the high contact resident care, and has resulted in some citations. So I think this is something that staff could use continuing. Updated and continuing education as to the entirety of enhanced barrier precautions, but particularly around what constitutes a high contact resident care activity. And that's what I have for you today.
Great, thanks, Chad. Does anyone have any questions for Chad?
Chad, what would you use as a resource to determine what those, like, is there a comprehensive list of those situations where enhanced barrier precautions are required?
There are. It's not all inclusive. So I think that you have to look at the need for contact during the particular care area. As Dr. Eber has noted, CDC has a great list, as well as the State Operations Manual now details in F880 what constitutes a high contact resident care activity. Again, it's not an all-inclusive list, but I think you can look at the care that's being provided and draw parallels to perhaps this is an activity where added protection is needed to prevent the transmission of specific particular MDROs.
Thank you so much.
Great, thank you. I think
Okay.
for the last few minutes, Singh has we wanted to talk to you guys about a short form, maybe for the next few monthly meetings.
Yes, and just as Chad was talking about, the surveyor guidance had changed at the end of April. And I don't know about your teams, but the teams that I work with and the facilities I work with have been very heightened alertness, I guess, about these changes. And a lot of different reports are coming into me and questions and some confusion. So we'd love to hear from you, our CMDA members. What kind of experiences are you having since the surveyor guidance has changed? What kind of solutions and answers should we be asking and looking for? And I can start with a couple of questions that have come in from my team and see if we have some experts on this call who might want to weigh in. The first one, I'd like to direct to Dr. Leslie Eber, who was Medical Director of the Year for Pulp Med a couple years ago. So maybe some insight from you, Dr. Eber, would be very useful. But we've been hearing from some of our providers that we're very aware that the new surveyor guidance includes increased responsibility and accountability for medical directors to be upholding the standard of care and also to be interacting and providing feedback to providers in the facility. So, in your mind, what are effective ways of providing that feedback? I think what I've been hearing are some notably ineffective ways and sometimes not very, um, probably some poorly led efforts to give that type of feedback.
Yeah, I think that's a really good question. I think that now the collaboration between medical directors and clinicians in the facility are going to be more collaborative. They are going to be more notable, and we're going to be held accountable with this new QSO for that collaboration. And so how we work together is really important. I think it's really essential that medical directors are only, I think, effective if they have good working relationships with all the clinicians and the nurses and the teams in the facility. If we're at odds with one another, that doesn't usually pan out. So I think giving feedback to our fellow colleagues and how we do that is really essential. So are we doing it in a respectful sort of way, a collaborative sort of way? Are we doing it at the nurses station? Are we doing it privately? Are we asking questions, or are we kind of, making demands or not hearing what everybody's perspective is? So I think that how we give feedback is really, it's so important. And I think we can do it in a really useful way in which we all can learn from each other. And I think that that is always such a benefit. I learn every day from everybody I work with. So I think it's really important that we just be really mindful of our community, that we want to work together, we want to be respectful of one another, and we want to hear how things are going and how we can be solution-driven problem solvers instead of kind of upping the ante of, oh my gosh, we have to fix this in the next 4 minutes. So that's my perspective. What are other people's perspectives? What has worked for others?
Definitely appreciate that, Dr. Eber, because I think I've gotten feedback from you in the past without even realizing I was getting feedback. And that's probably one of the more helpful ways. Well, here's another question that has come up. Maybe I'll direct this at you, Dr. Horton, or anyone who might have some input. We've been hearing that there might be some special documentation required, or perhaps just more scrutiny on PRN medications, maybe PRN medications for psychiatric use or for pain. In your facilities, Dr. Horton, are there some different advice that you're giving for PRN medication use? And we can certainly open up to anyone on the call as well.
Yeah, probably in the last year sometime. I've been working for PRN medications, a couple things. One, I've been working with my facilities to remind them to put a 2-week stop date on PRN narcotics. So when patients come from the hospital, especially if they've been recently started, because we know, and that's pretty generous. I mean, some people say 5 to 7 days, and that's not to say that they can't extend them after that, but it's kind of the same thing that the providers need to see it. We need to adjust and figure out why they're still needing PRN pain meds. And I work with a couple of facilities that don't allow any PRN antipsychotic or psychotics, of course, but anxiolytics and hypnotics. So Ativan, sleeping meds, some facilities don't allow any PRN use. And I've talked about that with my facilities as a viable option moving forward. And some of you guys might think that's really aggressive, but it can be done. Just so you know, there are facilities out there that don't allow it.
Dr. Horton, can I ask you a question on that? Because I'm curious, how do you guys manage your hospice patients then because we have facilities that are talking about moving away from PRNs. So do you have like best practice or advice on like managing end of life care if we're not utilizing like PRN, Ativan and those kind of things?
I mean, you might, it certainly could allow more leeway, right? As we all know, that if we have patients on hospice and they go past the 2 weeks, they can extend the PRN. So maybe you could carve out for hospice patients that are nearing the end of life. I think that's very reasonable. And I think that's an easily identifiable patient population for the nursing home to carve out. I imagine there are some nursing homes that are still trying to just schedule it. So maybe you do it PRN for a very short time, a few days to figure out when the need is and then schedule it. I don't know if there's anyone that, anyone else on the line that has buildings that are not using PRNs. It's a big step, or it can be. But we also have listened to we've listened to presentations where if you give a PRN, you may be supporting a bad behavior, or you may be reinforcing a behavior that you did not intend to.
Kind of a retroactive intervention, huh? Good. Well, thank you so much for sharing your experience and some tidbits and pearls there. I hope that we'll keep that conversation going because these surveyor guidance changes are certainly going to have an impact for us in the months moving forward. And we look forward to all of your input. Please submit your questions by email or feel free to speak up when we bring this topic up again next month. For now, I'm going to stop the recording and thank you so much for joining our monthly meeting. This coming Thursday is our CMDA Journal Club. And in case you missed or if you want to review the annual conference, Dr. Shepard did put the recording of the annual conference onto our website, cmda.us. So feel free to look at the videos online.